Good afternoon. I will start directly because of lack of time. We all know that Cincinnati guidelines were published about 2 years back and addressed various issues as far as turners were concerned, right from growth, puberty, to cardiovascular risk factors, to transitional care and everything. So in my talk, I'm going to address these 5 or 6 issues by presenting 1 or 2 papers which have been published recently addressing the turners patients. The Cincinnati guidelines, which were published 2 years back, said, as far as puberty were concerned, that estrogen replacement should be started around 11 to 12 years of age. The dose should be gradually increased to reach an ideal dose in 2 to 3 years. Progesterone should be added after breakthrough bleeding occurs or after 2 years of treatment with estrogens. And low dose E2 is preferred, though transdermal route can also be used. A group of SP Turners working group came out with this paper this year, and they thought that the puberty issue were not addressed adequately by the Cincinnati guidelines. What they wanted to do was to see if 17-beta estradiol, either given orally or in transdermal form, would be useful to induce puberty in the girls of Turner syndrome. So what they proposed was, this was the international prospective cohort study, where the clinicians and families were invited to choose either between oral or transdermal form, and usually started at the age of 11 years so as to mimic the normal puberty. The hypothesis which was thought was that the pubertal induction with transdermal estradiol will result in better outcomes, and the primary outcome measure was selected to be the height gain at the end of 3 years of induction period. The difference in this protocol was that this is for the oral 17-beta estradiol. The difference here was that the dose of estradiol was based on the weight of the child and not a fixed dose. It was started in the first year, and for 3 years it was given as induction dose, and the 4th year it was continuing at the maintenance dose. The recommended dose here in the first year was 5 micrograms per kg per day, increased to 7.5 micrograms per kg per day in the second year, 10 in the third year in the first 6 months, and 15 in the next 6 months in the third year of induction. The children or the girls in whom the final height was expected to be very low, additional dose of 7.5 was continued for 6 months between the second and third year. The dose, maintenance dose in the 4th year on average was 1 to 4 milligrams in the patients as a maintenance dose. As far as the transdermal estrogen which was concerned, it was available in the form of patches, and the patch strength was anything between 25 to 50 micrograms per day. Here they recommended that the patch could be cut in a smaller size to use the desired dose. And the advantage was that once you cut the patch, the remaining patch can remain stable for about 30 days. So you could use the same patch again, decreasing the cost of transdermal patch therapy in patients with Turner syndrome. Again, they recommended a protocol for transdermal patch. In the first year, dose was again based on the weight, less than 40 kg, between 40 to 55, and more than 55 kg. Second year, the dose was doubled, and again increased in the third year. Now, the patch was applied for 10 to 12 hours in the night time. In the third year, the dose was divided into 2 patches, into 2 halves. The patch was applied for the night time. In the morning, 1 half of the patch was removed, and the other half was left for next 12 hours. Night, the remaining half was removed, and 2 new patches were applied. This was done to maintain the diagonal variation and give the increased dose of estrogen in the night time. In the 4th year, the middle dose was reached, and the level of estrogen was checked and tried to maintain between 150 to 450 picomoles per liter. So this was as far as the 17-beta estradiol was concerned. They also addressed the issue of progesterone therapy in patients with Turners. Now, what Cincinnati guideline tells us was that to add progesterone after 2 years of therapy or once the bleeding has occurred. But what these people found out was they said that we want to allow maximum time for uterine and breast development by unopposed estrogen action. So along with clinical assessment, one could do a sonography, a USG, and assess the uterine size and endometrial thickness. If the endometrial thickness was very thin and the uterine size was normal, one could defer adding progesterone for a subsequent time. But if we found a thickness which was adequately thick and the uterus was mature, one could add progesterone early. So what they essentially wanted to tell us was that the transdermal protocol proposed in this study attempts to mimic normal puberty as closely as possible, and we could use transdermal regime, and it could turn out to be potentially cheaper if we are going to cut the patches into smaller size and use it. As far as growth in Turner syndrome was concerned, I came across this paper where near adult height in girls with Turner syndrome treated with growth hormone therapy, either with induced puberty or with spontaneous puberty, was analyzed. The objective was to know if there was a difference in patients with spontaneous puberty or induced puberty, the type of estrogen which was used, and they were on growth hormone therapy. So they searched the internet database and found 772 girls who were Turner syndrome, followed on growth hormone therapy from initiation to near adult height. Out of the 772, 145 girls had normal spontaneous puberty and 627 of them were on induced form of puberty. The starting dose of growth hormone, the starting age of growth hormone, and the height SDS were almost equal in both the groups. What they found out was that spontaneous puberty was initiated, the girls with spontaneous puberty reached adult height earlier than girls with induced puberty. Although spontaneous puberty grew more in the first year of growth hormone therapy and between the onset of puberty and near adult height, the height SDS at near adult height and length of time in puberty in both the groups was comparable. So they concluded that girls with Turner syndrome with spontaneous puberty tended to grow better with growth hormone in the first year of therapy, but did not have enough evidence to produce difference in height SDS at near adult height. Another interesting paper which I came across was, could anthropometric variables be used as predictors for cardiovascular risk factors in patients with Turner syndrome as adults? This was done in one center in Latin America, where they analyzed 57 girls with Turner syndrome. The biochemical variations, body compositions, and anthropometric parameters were analyzed. Obesity or overweight, metabolic syndrome were diagnosed using international consensus. The area under the curve was formed for each of these variables. What they found was that metabolic syndrome was seen in almost 40% of girls with Turner's, and overweight or obesity was seen in 48% of the study group. And interestingly, they found out that waist to height ratio was found to have a higher correlation with cardiometabolic risk factors as compared to BMI, waist circumference, or the waist hip ratio. So the suggestion was that the prevalence of metabolic syndrome and overweight obesity was high in Turner's, we know that, but the suggestion was that waist to height ratio being most useful variable which was found in this study, we could use it along with BMI or waist circumference as a best clinical utility tool to identify patients with Turner's who are at risk of developing obesity or metabolic syndrome. Similarly, one more paper from Belgium tried to study the disproportionate and dysmorphic features in adults with Turner syndrome and the risk factors for development of chronic diseases. The objectives of this paper was to analyze dysmorphic features and body disproportions in Turner's in relation to the chronic diseases and document the effect of growth hormone therapy on body disproportions. Again, it was a one-center study where 76 girls of Turner's were analyzed. Out of 76, 44 of them agreed to be measured for various body proportions. A scoring system for dysmorphism, craniofacial dysmorphism, thoracic limb abnormalities was developed, and the results were interesting. Turner syndrome with higher dysmorphism score were at a more risk of developing hypertension, as well as those who had a higher sitting height to standing height ratio. Prevalence of hypertension, osteoporosis, type 2 diabetes was lower in Turner's girls who were treated with growth hormone in childhood. The conclusion which they drew from this was that adult Turner women with relatively short legs or with most clinical dysmorphic features were more likely to have a risk of developing hypertension, and growth hormone therapy does not seem to increase the risk of chronic disease in the long term. The next issue which was to be addressed in Cincinnati guidelines was genetics and epigenetics, and I found two interesting papers on them, so I'd like to present them. As far as genetics and epigenetics in Turner's was concerned, what they say is the origin of Turner specific comorbidities may have a complex relationship between the genes as well as the transcriptional and epigenetic factors affecting these genes' expressions. In this study which was published, they found 3 or 4 genes which have specific relations with Turner syndrome. The KDM6A, which is important for germ cell development, was shown to be differently expressed and methylated in Turner's and Klinefelter syndrome patients. The T1MP1 and T1MP3 genes seem to affect the prevalence of bicuspid aortic valves in patients of Turner's, and KDM5C gene could have a role to play in the neurocognitive development in patients of Turner's. This is only one paper, and according to them, which is rightly said, they require more literature and more studies to confirm the association of these genes with Turner's. But one paper where congenital hyperinsulinism in infants with Turner syndrome was done, and it was found there could be a haploinsufficiency of KDM6A gene in these girls with congenital hyperinsulinism. So haploinsufficiency for KDM6A due to mosaic X chromosome monosomy may be responsible for hyperinsulinism in Turner syndrome. So we know now that KDM6A gene has a role to play in various manifestations in patients with Turner's. There was one more interesting paper where we found low bone mineral density and renal malformation in a group of Mexican patients associated with single nucleotide variations in vitamin D metabolism. Just to say in one line, the genetic background of Turner patients contributes to clinical variability seen in them, which could have a genetic mechanism for expression. And the last paper, which I would like to quote, is brain development in school-age children and adolescent girls, an effect of Turner syndrome, estrogen therapy, and genomic implanting in them. The background was interesting. They said that Turner syndrome offers a unique window of opportunity for advancing scientific knowledge of how X chromosome gene imprinting, epigenetic factors, and hormonal milieu affect brain development in females. They studied 55 normal girls and 53 girls with Turner syndrome over a period of 5 years by doing 258 MRI scans. These scans were evaluated by using novel techniques, and the results showed that the parieto-occipital gray matter and white matter regions grew slower during typical pubertal timing in girls with Turner's as opposed to the normal children. In contrast, some basal ganglia, cerebellar regions showed enhanced volume of growth, which peaks around 10 years of age. What they concluded was the parieto-occipital finding in these girls tell us that Turner syndrome girls may be particularly vulnerable to altered brain development during adolescence, whereas basal ganglia regions may be preserved because their maturation happens earlier during early part of puberty. And this specific alteration in neurodevelopment could have long-term cognitive behavioral outcomes in children with Turner's. Thank you.